Although we face tough circumstances these days, we can still connect and reach out to one another, even if we are in different governorates, as long as we have the same goal, which is to help more patients receive the better treatment and enjoy extra moments with their beloved ones. So, welcome to The Live, the premium live platform for cardiologists. Our live virtual webinars with open windows for double-way communication, discussions, and questions over a period of 6 months, starting on 11th of May. Hosting the top experts in cardiology, Professor Mohammed Subhi, Professor Ashraf Rida, Professor Ihab Atiyah, Professor Hisham Abul Anin, Professor Tariq Zawawi, Professor Nabil Farag, Professor Mohammed Satiha, Professor
هاني راجي,
Professor
حسام أنديل,
Professor
أيمن أبو المجد.
Stay tuned. Brought to you by Byer.
Hello everybody. I would like to welcome you in today's webinar, and I would like to thank Byer Company for educational support for the CME activities. Today's webinar I'll have the pleasure to have with me Professor Dr. Nabil Farag, and this is part of the Live program. I think this is the second series. We have a meeting in last CardioAlex, and we have, I think Byer is preparing a large program regarding this project. And the agenda of today will start with Professor Dr. Nabil Farag. He will talk to you about the evolving definition of valvular atrial fibrillation. After that, there will be a couple of questions from the participants, and I'll present then another presentation about the protecting atrial AF patient with diabetes and atrial fibrillation, and we'll finish with a discussion. And I have the pleasure now to introduce my dear colleague and friend, Professor Nabil Farag, the Vice President of IAVA Society, about the evolving definition of valvular AF. Professor Nabil.
Thank you, Dr. Ashraf, for this introduction. I would like to thank Byer team, all of you, for this event and for the great organization of this event. This is my presentation today about the evolving definition of valvular atrial fibrillation. I would like to give a small introduction about some facts about the atrial fibrillation. And we have to know that atrial fibrillation is the most common cardiac arrhythmia, as it affects 1 to 2% of the general population, projected to increase steadily with aging demographic. And patients with atrial fibrillation have a 5-fold increase in the risk of stroke. And the origin of stroke in most of the patients are mostly thromboembolic, arising from the left atrial appendage. Atrial fibrillation-related strokes are more debilitating, as I will show you later, due to the size of the clots. Usually, it has a large clots that cause a more severe stroke and more severe debilitating disease. And stroke is the #1 cause of long-term disability and the third leading cause of death worldwide in patients with atrial fibrillation. And this is the AF prevalence. In the general population, it occurs, as we said before, in 1 to 2% in the general population. But as we get older, this prevalence increases. And in patients above the age of 60 years, below the age of 80 years, the incidence is about 4%. And those above the age of 80 years, it approaches 10% prevalence of atrial fibrillation in this group of patients. And usually, the AF-related stroke are associated with greater disability and a higher mortality rate. And as we see here that at clinical presentation, there was severe limb weakness. And this severe limb weakness is more pronounced in patients with atrial fibrillation as compared to those without atrial fibrillation. And the bedridden is much more in patients with atrial fibrillation than those without atrial fibrillation. And the 30-day post-stroke mortality is significantly higher in patients with atrial fibrillation than those without atrial fibrillation. And this shows how great is the burden of patients presenting with stroke due to atrial fibrillation. What about the definition of valvular or non-valvular atrial fibrillation? This is all over the clinical trials and the guidelines. The proportion of patients with valvular atrial fibrillation ranges from 4 to 30% of all patients with atrial fibrillation. 4 to 30%, actually, this is a great range and great variability. And this variability is mostly due to the lack of unique definition of what valvular or non-valvular atrial fibrillation is. This means that actually we don't have a standardized definition of valvular or non-valvular atrial fibrillation. So the definitions of valvular, non-valvular atrial fibrillation adopted by authorities and by the guidelines have changed in their different editions, and sometimes they are in contradiction with each other. And I will show you in the different clinical trials later on and in the guidelines that this definition of valvular atrial fibrillation are actually different from each other. And the studies on the definition of valvular, non-valvular atrial fibrillation are lacking. We don't have a clear study that define atrial fibrillation in a standardized fashion. So actually, we don't have a standardized definition of valvular or non-valvular atrial fibrillation. And this is the aim of my presentation. I would like to highlight on the definition and to reach a final definition or standardized definition of valvular atrial fibrillation. And we got the definition indirectly of valvular and non-valvular atrial fibrillation by the most recent clinical trials on stroke prevention in atrial fibrillation patients, comparing non-vitamin K antagonist oral anticoagulants to warfarin. And in the main trials, the exclusion criteria were different in the different trials. For example, in Aristotle trial, comparing apixaban with warfarin, they excluded patients with significant mitral stenosis. Significant mitral stenosis, we mean that moderate and severe mitral stenosis. And patients who have atrial fibrillations that require chronic anticoagulation, for example, prosthetic mechanical heart valves. So in Aristotle trial, the main exclusion criteria were significant mitral stenosis, moderate and severe, and those with a mechanical heart valve. In Engage AF, comparing endoxaban with warfarin, the exclusion criteria were moderate and severe mitral stenosis and mechanical heart valve, exactly like Aristotle, but they added on this patient with unresected atrial myxoma. What about the exclusion criteria in the RELY, comparing dabigatran with warfarin? They excluded patients with heart valve disorders. Any patient with heart valve disorders are excluded. For example, patients with mitral regurgitation, patient with aortic regurgitation, patient with aortic stenosis, patient with mitral stenosis, and patient with a mechanical heart valve. So added to moderate and severe mitral stenosis are patients with mitral regurgitation, aortic regurgitation, and aortic stenosis. And these were the main exclusion criteria in the RELY study comparing dabigatran with warfarin. And in the ROCKET AF, comparing rivaroxaban with warfarin, they excluded only hemodynamically significant mitral valve stenosis, like moderate and severe mitral stenosis and prosthetic heart valves. And these were the main exclusion criteria in the ROCKET trial. And in the Everise, comparing apixaban with aspirin, the exclusion criterion was valvular disease requiring surgery For example, severe mitral stenosis, severe aortic stenosis or aortic regurgitation in addition to a mechanical heart valve. So in all of these clinical trials, we don't have a standardized definition of valvular atrial fibrillation. Again, and this is the aim of my presentation, to reach to a standardized definition of valvular atrial fibrillation. What about the guidelines? In 2008, the American College of Chest Physicians defined valvular atrial fibrillation are those with mitral stenosis, whatever the severity is, mitral stenosis, mild, moderate, or severe, and prosthetic heart valves. And the American Heart Association, American College of Cardiology, they define patients with valvular atrial fibrillation as those with rheumatic mitral valve disease, again, any form of mitral valve disease, prosthetic heart valve, and they included as well mitral valve repair. And as we know that patients with mitral valve repair, usually they don't, without atrial fibrillation, usually they don't require anticoagulants after 3 months of the repair. But this was an exclusion criteria, or this is one of the definition of valvular atrial fibrillation. In 2016, European Society of Cardiology was very clear that defined patient with rheumatic valvular disease, predominantly mitral stenosis or significant mitral stenosis, moderate and severe, or prosthetic heart valves are those who defined to have valvular atrial fibrillation. Only moderate and severe mitral stenosis and those with prosthetic heart valves. So we have different definitions based on the clinical trials comparing NOACs with warfarin, and even we have different definitions of valvular or non-valvular atrial fibrillation in the different guidelines, American, European guidelines. And based on this thorough review of all of this, of the clinical trials, based on the review of the definition of valvular atrial fibrillation in the guidelines, and in the clinical trials comparing NOACs with warfarin or aspirin for stroke prevention in atrial fibrillation, we proposed a definition of valvular atrial fibrillation to be a valvular atrial fibrillation to be defined in patients with rheumatic mitral valvular atrial fibrillation, moderate and severe stenosis. So mild stenosis is not considered a valvular atrial fibrillation. And patient with mechanical heart valves, whatever it's a mitral or an aortic mechanical heart valves, this should be defined to have valvular atrial fibrillation. And conditions other than atrial fibrillation that required anticoagulations. For example, patients coming with left ventricular thrombus and developed atrial fibrillation. He needs anticoagulant other than the atrial fibrillation for the left ventricular thrombus. This is considered like valvular atrial fibrillation. And also, patient with unresected atrial myxoma, who still having atrial myxoma, can be dealt with exactly as those with valvular atrial fibrillation, so can be dealt with as patient with moderate and severe mitral stenosis or patient with mechanical heart valves. And patients with native valvular heart disease other than moderate and severe mitral stenosis, for example, patient with aortic regurgitation, patient with aortic stenosis, or patient with mild mitral stenosis are considered a non-valvular atrial fibrillation. Patient with bioprosthetic heart valves, tissue valves, patients who have a tissue valve in the mitral position or in the aortic position are excluded, and considered as non-valvular atrial fibrillation. Patients who have annuloplasty with or without prosthetic ring are also considered a non-valvular atrial fibrillation, and those with commissurotomy and or valvuloplasty, for example, balloon mitral valvuloplasty reaching a mild form of mitral stenosis are considered a non-valvular atrial fibrillation. So, to summarize again, the definition of valvular atrial fibrillation is only related to those with significant mitral stenosis, moderate and severe mitral stenosis, and those who have a mechanical heart valves, those with unresected atrial myxoma, and those who have other indications for anticoagulations other than atrial fibrillation, for example, patients with left ventricular thrombus, and patients with native valvular heart disease other than moderate and severe mitral stenosis, patients with bioprosthetic heart valves, patients with annuloplasty with or without prosthetic ring, commissurotomy and or valvuloplasty can be treated as exactly those as non-valvular atrial fibrillation, and this excluded from the definition of valvular atrial fibrillation. Going back to the guidelines, now NOACs are considered the new standard of care for stroke prevention in eligible patients with atrial fibrillation, and this is the recommendation by both the European Society of Cardiology and even the Heart Rhythm Association, that they mentioned very clearly that when oral anticoagulation is initiated in a patient with atrial fibrillation who is eligible for non-vitamin K oral anticoagulation, for example, apixaban, dabigatran, edoxaban, or rivaroxaban, NOAC is recommended in preference to vitamin K antagonists, and this considered class 1 recommendation, level of evidence A. And again, NOACs, dabigatran, rivaroxaban, apixaban, and edoxaban are recommended over warfarin in NOAC-eligible patients with atrial fibrillation, except for those moderate to severe mitral stenosis or a mechanical heart valve. As we mentioned before, these are the definition of valvular atrial fibrillation. And this is based on the EHRA guideline. They considered patients with mechanical heart valve, patients with moderate to severe mitral stenosis who develop atrial fibrillation. In this type of patients, NOAC are absolutely contraindicated. So we don't use NOAC in this type of patients. And again, back to our definition, these are included in the definition of valvular atrial fibrillation. Other forms, for example, mild to moderate other native valvular disease, mild moderate aortic stenosis or regurgitation, degenerative mitral regurgitation, and even mild mitral stenosis can receive NOAC and considered a non-valvular atrial fibrillation. See, even severe aortic stenosis can consider a non-valvular atrial fibrillation and can receive NOAC. And patient with bioprosthetic valve after 3 months also can receive this type, but usually the advice, if this bioprosthetic valve is done for a patient with rheumatic severe mitral stenosis, they advise, but this is not absolute contraindication. They advise not to use NOAC, but it's acceptable for all degenerative mitral regurgitation or in the aortic position. Again, mitral valve repair, which was an exclusion criteria in one of the major clinical trials we mentioned before. Now, mitral valve repair is considered a non-valvular atrial fibrillation, and they are eligible to receive NOAC. And patient with transcatheter aortic valve implantation or pulmonary transcatheter aortic valve implantation, all of these patients, when they develop atrial fibrillation, they are eligible to receive NOAC. And patients with heart muscle disease, for example, with hypertrophic cardiomyopathy, again, they are eligible to receive NOAC. So the main contraindication for NOAC, what we call a truly valvular atrial fibrillation, are those with moderate to severe mitral stenosis and those with mechanical heart valves. Thank you for attention. Waiting for your question.
Thank you, Professor Nabil. Actually, this is very important because if we are talking about moderate or severe, I think we should give some advice about for example, the GP about the moderate and severe mitral stenosis, for example. Because if I wanted to come with a conclusion, I think the main conclusion is we have to know when is our patient moderate or severe mitral stenosis. Prosthetic valve is okay; it's very clear. What's your advice in a definition of moderate and severe mitral stenosis?
As we all know that the definition of moderate and severe mitral stenosis is in the guidelines that patients with a mitral valve area of less than 1.5, more than 1 centimeter, is considered a moderate mitral stenosis, and patient with a mitral valve area of less than 1 centimeter is considered a severe form of mitral stenosis. Patient above the mitral valve area of 1.5 is considered a mild form of mitral stenosis. And these are the main definition of moderate and severe mitral stenosis. And these are patients who, when they develop atrial fibrillation, are considered to have a valvular atrial fibrillation.
Well, if Sharif with us, if there is any question, Sharif,
Yes.
from the
Yes,
participant.
I'm with you. Exactly. Yes. Thank you, Professor Nabil, for your elegant presentation, which made it quite clear the definition of valvular atrial fibrillation now, which is the moderate to severe mitral stenosis or prosthetic heart valve. We have some questions from the audience. The first one is that are NOACs contraindicated in valvular AF? This is the first question.
Yes, valvular AF, again, back to the definition of what we mean valvular AF, because if we have patients with a mitral regurgitation, if we have patient with aortic regurgitation, if we have patient with aortic stenosis and developed atrial fibrillation, this is non-valvular. Again, it is very clear now to know what we mean by valvular atrial fibrillation. And valvular atrial fibrillation means only patient with moderate and severe mitral stenosis or patient with a mechanical heart valves. Only these patients, when they develop atrial fibrillation, are considered to have an valvular atrial fibrillation, and these patients are not eligible to NOACs. Any other patients, apart from this, moderate severe mitral stenosis, mechanical heart valves, or unresected atrial myxoma, any other patients, whatever the etiology of atrial fibrillation, mitral regurgitation, aortic stenosis, patient with bioprosthetic valve, patient with mitral valve repair, even those who have a ring with the repair, all these patients are eligible to NOACs and considered as non-valvular atrial fibrillation.
Thank you so much.
Other questions, Sharif?
Yes. It's a question which completes the previous one. So why are NOACs contraindicated in valvular AF patients? Why are they contraindicated?
Because these are the patients these are the patients that were excluded from the major clinical trials. So we don't have a study actually on this type of patients. We don't have a study using NOACs in patients with mechanical heart valves. We don't have a study on patients with moderate and severe mitral stenosis. But some of the major randomized clinical trials like Aristotle, like Rely, Rocket, Engage, all of these trials included, some of these trials included patients with mitral regurgitation, aortic regurgitation, and aortic stenosis. And so we have studies in this type of patients, but we don't have studies on the patient I mentioned, mechanical heart valves, moderate and severe mitral stenosis. That's why we can't, till now, we can't use a drug without evidence, without a background clinical study. Maybe in the future, we will have a trial on mechanical heart valves. We'll have a trial in a patient with moderate and severe mitral stenosis. Till we have these trials, we shouldn't use NOACs in patients with valvular heart disease as I defined in my presentation.
I think, Dr. Nabil, there is an ongoing study, and some of the Egyptian center may be involved about patients who are not well controlled or could not be controlled with warfarin with prosthetic valves. Of course, there is no data yet. Anyway, thank you for this very illustrative presentation, Professor Nabil. And if there is no other question, Sharif, I think we can take half a minute break and then be with us, and we'll come back in half a minute.
There is only one question, which is so now how to switch from warfarin to Xarelto?
This is very, very important questions because we may see some patients coming to your clinic receiving warfarin for their atrial fibrillation, and these patients are NOAC eligible. And their INR is fluctuating up and down, and the INR control is not good for these patients. And sometimes patients asking for a drug that doesn't need regular monitoring by INR. So in this condition, we have to switch between warfarin and NOAC. How can we switch? First, you have to stop warfarin for 3 to 5 days. And after 3 days, we have to check for the INR. We have one of these three. If we have an INR below 2, in this condition, you can start immediately NOAC. If the INR between 2 and 2.5, you have two options, either to start NOAC immediately or to wait for another day and you start the NOAC second day. But if we have an INR above 2.5 to 3, in this condition, you have to wait for another 1 or 2 days and to recheck the INR. And when the INR reaches to below 2, in this condition, you can easily switch to NOAC and you can start immediately NOAC. So the INR is a parameter, is a monitor. Based on the level of this INR, you can start immediately the NOAC. If the level is below 2, you can start immediately NOAC.
Thank you, Professor Nabil. Thank you so much.
So half a minute of break and then be with us and come back.
Back again to you, welcoming you all, and I would like to introduce my dear friend, Dr. Ashraf Rida. Dr. Ashraf Rida is a professor of cardiology at Munofia University, and he is the president of the IAVA Association, and is a director of the Egyptian CardioResc project. And all of us know what is the CardioResc project, and actually, by this project, we did a lot of registries and studies that published abroad. I'm welcoming Dr. Ashraf, and I have the pleasure to introduce you to give this important presentation, protecting patients with atrial fibrillation and diabetes.
Thank you, Professor Nabil, and again, I would like to thank Byer for their enthusiasm in supporting this important CME activities, Z-Live. Anyway, I will present to you now about patient. If you have a patient with atrial fibrillation and diabetes, I think we have many questions here. What is the problem of being together, these two different pathology, atrial fibrillation and diabetes? And what is the risk we have, and how we can reduce the different cardiovascular and stroke risk in this category of patients. Why this is a problem? I think it's a problem because about 40% higher risk of developing atrial fibrillation in patients with diabetes. So if you have a patient with diabetes, you have a yearly risk increase of about 3% per year of diabetes mellitus, and a 40% higher risk of developing atrial fibrillation relative to patients without diabetes. So you may encounter in your daily practice many patients with diabetes with atrial fibrillation in the same time. So what is the problem if you have a patient with diabetes? The problem is that diabetes itself is a risk factor for atherosclerotic cardiovascular disease. And both of these two pathology, whether diabetes or atherosclerotic cardiovascular disease, can develop atrial fibrillation and have a pathological mechanism that can contribute to the development of atrial fibrillation. So if you want to ask questions about what are the mechanisms, why the insulin resistance of diabetes mellitus can convey increased thromboembolic risk through various means. And this risk is due to, first of all, induced hypercoagulability. With insulin resistance, with diabetes, it is a type of hypercoagulability state. Also, we have endothelial dysfunction. As you know, diabetes, insulin resistance, and the effect of hyperglycemia itself lead to endothelial dysfunction. We have also impaired fibrinolysis. So the risk of diabetes itself carry a higher risk of developing thromboembolic complication. In addition, of course, to the risk of thromboembolism with the presence of atrial fibrillation. So we have double risk or exaggerated risk of thromboembolism if you have the patient with these two pathology, diabetes and atrial fibrillation. So patient with atrial fibrillation and diabetes actually is an important subgroup of patients, because this combination is a real worldwide problem actually. As it was shown in the previous slides, it's 40% of diabetic patients may have atrial fibrillation. And of course, it is a problem because diabetes is not only diabetes, it's commonly associated with other risk factors like hypertension, like heart failure, like cardiomyopathy. And as we know, these risk factors in itself are independent risk for chronic atrial fibrillation. The mechanism of diabetes-related atrial fibrillation and its pathophysiological link الحقيقة need epidemiological study, need registries to understanding the mechanism of atrial fibrillation with diabetes. However, we can summarize this mechanism in these three important pathological situations. Inflammation, and we know that inflammation is present in diabetes, and inflammation is also present in patients with atrial fibrillation. And the inflammatory process in the endothelium can lead to thromboembolic complication. The second mechanism is due to the possible direct effect of the glucose and the insulin abnormalities on different part of the heart, like cardiovascular system, atrial, ventricular myocardium, with consequence of left ventricular mass, left ventricular hypertrophy. This is the second mechanism. The third mechanism is the disturbance of the autonomic nervous system, which is another important pathophysiological mechanism known in patients with diabetes. So we can summarize that we have three mechanisms of atrial fibrillation in diabetic patient: inflammation, glucose and insulin abnormalities, and the autonomic dysfunction. This is the mechanism by which diabetes by itself can lead to atrial fibrillation. Of course, as I told you, there is other comorbidities in diabetes that, like hypertension, like cardiomyopathy, ischemic heart disease, which in itself, even without the effects of diabetes, can lead also to atrial fibrillation. So why this combination is annoying? Because with this combination, AF and the diabetes, we have worse AF symptoms. We have more limb events and limb ischemia. Diabetes can cause limb ischemia by its effect on the peripheral vasculature, and atrial fibrillation, if it leads to systemic embolization, can aggravate these problems. We have higher mortality rate in patients with diabetes and atrial fibrillation compared with diabetes alone or compared with AF alone. Also, of course, it was very clear in the mechanism of action of both situations, we have increased risk of systemic embolization. Another important part in this combination is the implication of diabetes on the kidney function. We know that the incidence of chronic kidney disease and even of end-stage renal disease and dialysis is important or significantly high in patients with diabetes. And if there is left renal dysfunctions, we have a problem here. We have a problem in choosing the proper anticoagulation in determining the dose of the anticoagulant used according to renal function, as we will see in the coming slides. Let us discuss a case. Let me call him Mr. A. And Mr. A is 76 years old with non-valvular atrial fibrillation. I think Professor Nabil had explained very clearly what is the meaning of non-valvular atrial fibrillation. The absence of moderate to severe mitral stenosis, the absence of prosthetic valve or left myxoma liable to resection. So 76 years, non-valvular AF, diabetes, and moderate renal impairment, creatinine clearance 46. So Mr. A is afraid because his friend is diabetic patient. He is complicated with end-stage renal disease and dialysis, and he asks you to protect him from the complication of diabetes and atrial fibrillation, especially renal function and limb ischemia, for example. So first of all, we have to know that the problem of renal dysfunction is very important. This guy is 76 years with diabetes and with moderate renal dysfunction. And we have to know that kidney disease occurs in around 1 in 3 patients with type 2 diabetes. Diabetes is a major cause of kidney failure that may require dialysis. And of course, patients with diabetes and renal dysfunction are more likely to develop cardiovascular event, atherosclerotic cardiovascular disease. The problem of age, this guy is 76 years old. And we know that, as Dr. Nabil explained and illustrated, that with advancing of age, the incidence of AF is higher, and here is from 1.5% to around 9% in this age group, and even 23% when the patient is above 80. So now we have to look at these patients. We have to assess his thromboembolic risk, his bleeding risk. We have to deal with his diabetes, his atrial fibrillation, and his moderate renal dysfunction. And we have to know that this triage, atrial fibrillation, kidney disease, and diabetes, substantially increased the risk of stroke. AF itself associated with 5-fold increase in the risk of stroke. Chronic kidney disease, you have 30 to 60% increase in the risk of stroke. Diabetes associated with 2-fold increase in the risk of stroke. So we are dealing with a situation in which the risk of stroke is substantially very high. And you know, the disability with a stroke in this age group that can be even life-threatening in this age group, age category. So I think no questions that our patients will need anticoagulation. So the first question is vitamin K antagonist or NOAC. And by NOAC now, this abbreviation means non-vitamin K oral anticoagulant. So VK or NOAC, let us look at these illustrative slides. Actually, most patients with type 2 diabetes and the new onset F require long-term anticoagulation, because if you put this patient on any risk score, Chad's risk score, he's 76 years, he has renal dysfunction, he has diabetes, so definitely he will need long-term anticoagulation. Why direct anticoagulant or NOAC may be preferred over warfarin in patients with type 2 diabetes and AF? Actually, in general, NOAC is preferred in non-valvular AF, and as we will see in the guidelines, because of the favorable safety profile, proven efficacy compared with warfarin, and less drug-drug interaction as when we compare NOAC with warfarin. So that's why it's, generally speaking, it is preferred. And this is the guidelines of European guidelines 2016. It is very clear that NOAC is recommended in preference to vitamin K antagonist, and this is class 1 indication. Of course, when your patient is eligible for NOAC in the absence of moderate to severe mitral stenosis or prosthetic cardiac valve. The ACC has focus update last year, and again, it insists that NOAC are recommended over warfarin in NOAC eligible patients with atrial fibrillation. So now most of the guidelines actually recommend NOAC over warfarin when the patient is eligible for NOAC and in the absence of moderate to severe mitral stenosis or prosthetic hardship. Let us look at some data from the ROCKET trial of the rivaroxaban, and why we are presenting ROCKET now, because in ROCKET trial we have 40% of the patients involved are diabetic. Other AF trial of NOAC also including diabetic patient. In Aristotle trial there was 25%, and in RELY 23% is diabetic. In general, in ROCKET trial, in all patient group, rivaroxaban reduced the risk of vascular death and MI compared with warfarin. And what I wanted to highlight here is the subgroup of diabetes. So sub-analysis in patients with AF and diabetes in ROCKET trial, rivaroxaban reduced the risk of composite stroke, systemic embolization, vascular death, or MI compared to warfarin in the diabetic cohort with around 16% relative risk reduction. So actually, we have data that NOAC, rivaroxaban, is preferred over warfarin in generally and especially in patients with diabetes and atrial fibrillation. Here came an important question. Do we have just stroke prevention with rivaroxaban or as an example of NOAC, or is there any mortality benefit in addition to stroke prevention? Let us go to see some data from the ROCKET AF trial comparing the warfarin with rivaroxaban as regarding the stroke incidence, as regarding the cardiovascular death and the mortality related to fatal cardiovascular event. And actually there is 20% relative risk reduction in favor of rivaroxaban compared to warfarin regarding the cardiovascular mortality. So we are not just preventing the stroke, we improving the mortality, we're reducing the cardiovascular mortality by using rivaroxaban compared, and this is very important actually, because as we know that diabetic patients, especially those with chronic kidney disease, have a high prevalence of atherosclerotic cardiovascular disease and a high mortality from atherosclerotic cardiovascular disease. This is very important trial because this is data about patients above 80 years. This is very important because any of us, when we see a patient with 80 or 80 plus years, I think the first questions come to our mind: is it safe to give anticoagulation? What about bleeding? Can we reduce the dose? Should we reduce the dose? Let me reassure you about even in this category of high-risk patients, above 80 years, the mean age is 86 years, with a high SHAD VASCO score, a mean 4.6, and the HAS bleed score 2.1, 1 year follow-up. The compared with warfarin, the major bleeding, intracranial hemorrhage, and stroke are in favor of using rivaroxaban with less major bleeding, less intracranial hemorrhage, and less stroke compared to warfarin. So now we have, we can tell Mr. A that NOAC rivaroxaban can reduce significantly your risk of stroke compared to warfarin, can even reduce the cardiovascular mortality. Now, what about his questions about limb ischemia, which is, I'm sure that every diabetic patient is worried about having limb ischemia due to peripheral vascular disease. And of course, if you have a systemic embolization from AF, it will worsen the condition. So do we have data regarding the limb ischemia and, for example, the rate of amputation in patients with NOAC compared to warfarin? Yes, we have. This is retrospective claim analysis using US real-world data between January 2012 to December 2017. More than 13,000 warfarin users were eligible for study inclusion. similar major bleeding risk when compared to warfarin. However, the most important is that the risk of major limb amputation and endovascular revascularization separately were also lower with patients treated with rivaroxaban versus warfarin. So we have data, very important data about rivaroxaban efficacy in diabetic patients with non-valvular AF. We have 25% relative risk reduction of MACE, and we have 63% relative risk reduction of male. And by male, we mean major adverse limb effect. Of course, in addition to the cardiovascular MACE and peripheral male, we have 17% reduction in acute kidney injury and 18 lower risk of progression to stage 5 chronic kidney disease. So I think this is a very reassuring data about the using of rivaroxaban in elderly patients with diabetes and atrial fibrillation, and even in the presence of chronic kidney disease. And this is bar slides representing comparison between rivaroxaban and warfarin and limb event, adverse limb event male in patient with compared to warfarin, and is significantly lower in the rivaroxaban group. So this is again to confirm the priority of using rivaroxaban if you want to reduce the MACE, major adverse cardiovascular event, ischemic stroke and MI, and even the major adverse limb effect, especially major limb amputation and surgical revascularization, also endovascular revascularization, which is reduced in the group of patients taking. So what about the kidney? I think the renal function is very important in diabetic patients with atrial fibrillation who need anticoagulation. This is very important data telling us that using rivaroxaban compared to warfarin may lead to 17% reduction in acute kidney injury and 18% lower risk of progression to stage 5 chronic kidney disease or hemodialysis. If there is any explanation, yes, there is some explanation. We have recent data that warfarin can induce or can increase the vascular calcification, especially renovascular calcification, which may lead to worsening of the renal function, and this may explain why a drug like rivaroxaban has a favorable risk profile and even less degree of kidney progression and less need for dialysis and end-stage renal disease progression. This is the slides showing this previous data regarding patients with acute kidney injury and those who progressed to stage 5 disease. Blue line or blue bar is rivaroxaban, and the gray bar is warfarin, and there is significant risk reduction in both this grave situation in patients with diabetes. And another data to confirm that coming from the German non-valvular AF patient with concomitant diabetes, and actually in this data, it was clear that the risk of acute kidney injury was decreased by 28%, and the risk of end-stage renal disease was decreased by 68% among diabetics prescribed rivaroxaban versus oral vitamin K anticoagulation. Again, this is another retrospective database study of patients with non-valvular AF and diabetes. And again, if you compare the rivaroxaban versus warfarin, regarding the end-stage renal disease, regarding the acute kidney injury, there is favorable effects. The same also was present for apixaban, especially for the end-stage renal disease. However, for acute kidney injury, data in favor of rivaroxaban compared to warfarin. So coming to renal function, and important questions we will have. what is the adjustment of the dose if you have renal infarction? Especially our patient is 76. So the patient elderly, if the patient have renal dysfunction, well, the scheme for using the rivaroxaban and dose adjustment is actually very simple because you have just all you have is to estimate creatinine clearance, and if it is less than 15 milli per minute, not recommended. And the same for apixaban, less than 15, not recommended. However, above 15 for rivaroxaban, you can just give either 15 milligram or 20 milligram. If it is above 50, it's 20. If it is less than 50 milligram, and this is regardless of age. This is very important because you don't bother yourself in considering the age of the patient. It is safe to give an elderly patient with normal renal function the full dose of rivaroxaban. If there is moderate to severe kidney dysfunction, it is 15 milligram, less than 15 milliliter. We have no data. Regarding apixaban, there is some dose adjustment. It is a little bit more complicated than the scheme for the rivaroxaban because it depends not only on the renal function, but also on the weight of the patients and on the age of the patients. And if two factors are present, above 80, less than 60, and the renal dysfunction, you can reduce giving the reduced dose. So you have these schemes to adjust your dose for whether rivaroxaban or other agents for in patient with renal dysfunction. But the message here is that elderly patient with normal renal dysfunction, rivaroxaban full dose. If there is moderate renal dysfunction, 15 milligram is okay. So we have this simple dosage schedule. Rivaroxaban 20 milligram. It's better to be taken with food. 15 milligram if there is moderate to severe renal impairment, and this is regardless of the age. And it's better to be taken with food because in this situation you have 100% bioavailability if it's taken food. So by the end of our discussion, I think we can convince Mr. A, who is 76 years old, with non-valvular atrial fibrillation, moderate renal disease, and diabetes, is that NOAC rivaroxaban can, for these patients, for this risk category, diabetic plus AF plus moderate renal function, we can, by rivaroxaban, prevent stroke. We can preserve the renal function more than warfarin. We can reduce limb events, and even all these benefits are not on the expense of increased bleeding, because even the risk of major bleeding and are less in rivaroxaban compared to warfarin. In addition, you can by using rivaroxaban, reducing the cardiovascular mortality as compared to warfarin in the same patient. So thank you, and I wait if there is any questions from Professor Nabil or from the audience. Okay.
Thank you very much, Dr. Ashraf, for this great presentation. Actually, I enjoyed your presentation very much. Added to the benefit of anticoagulation, especially the NOAC and stroke prevention and atrial fibrillation, and as you mentioned, that the safety and efficacy of rivaroxaban in stroke prevention and systemic embolization prevention in patients with atrial fibrillation are in favor of use of rivaroxaban over warfarin. That's why the European Society of Cardiology and American College of Cardiology recommendations, they recommend NOACs over warfarin, and this is a class 1 recommendation, level of evidence A. And you explained very nicely the benefit of this important drug in the reduction in the progression of chronic kidney disease into end-stage renal disease and dialysis. And I think added to the stroke prevention in patients with atrial fibrillation, the benefit, we have to mention again the benefit in a reduction in the progression of kidney disease. Also, a very important point you mentioned, Dr. Ashraf, that diabetic patients, and as we all know that these patients are susceptible to have lower limb ischemia or chronic ischemia or acute ischemia in their lower limb, and this make them susceptible to amputation. And again, by use of this very important drug, the limb amputation was significantly reduced with rivaroxaban as compared with warfarin. So it's very important not only for stroke prevention and atrial fibrillation, but also for the reduction in the progression of chronic kidney disease and the reduction in limb amputation. I think for the sake of our patients, we have to use this drug in patients with diabetes and atrial fibrillation, and it's preferred over, definitely it's preferred.
And that's why the guidelines clearly put it as a class 1 indication.
Yes, for this, yes. If there are any questions for Dr. Ashraf.
شريف عندك أسئلة؟ شريف with us?
شريف.
So if there is no questions, I think Dr. Nabil,
أنا ممكن.
The two presentations were complementary, and you give us an important new data about the definition or the need of real definition of atrial fibrillation, valvular or non-valvular. And it is now clear that the most important thing is to know whether your patient have moderate or severe mitral stenosis or no, whether a patient prosthetic valve or no.
Yes.
And I think in the guidelines told us that it's class 1 indication to put in such patients NOAC. I know, and you know, that the cost is the main issue in preventing everybody to give NOAC for every patient, eligible patients. But especially in view of the pandemic we are living in, we wanted to try to reduce the contact between the patients and the lab, doing lab every now and then. So I think this is another important point that will convince us to using NOAC for most of our patients.
Ashraf, I had a problem with my connection.
شريف معانا.
مع حضرتك. كان في بس سؤال للبروفيسور أشرف regarding البيشنت اللي on dialysis. هل نقدر نديهم نواكس أو لا؟ AF patients on dialysis.
Well, I think a patient on dialysis, in this situation, I will consult the renal consultant, because you know that different NOACs have different dialyzable effects. We know that the one which is used, eliminated by the kidney, mainly is the dabigatran. So the dabigatran is nearly 80%, I think, or 70% eliminated by the kidney. But I think, I don't have any data, and there is, to my mind, there is no subgroup analysis in patients with who are on dialysis in using warfarin. You have any data, Sharif or Nabil, about that?
Dr. Ashraf, I read about this subject, patients with GFR or creatine clearance below 15, and those with end-stage patient on hemodialysis. وهم استعملوا فيهم فعلا one of two النواكس اللي هو ريفاروكسابان 15 ملغ او ابيكسابان 2.5 ملغ twice daily، وان هم دلوقتي هو this is not recommended by the guidelines, but they are not absolutely contraindicated in such patients. وفي trends towards استعمال الريفاروكسابان 15 ملغ and apixaban 2.5 twice milligram in a patient with end-stage renal disease, because we have some registry data, some real-world evidence. We have such patients, and maybe some patients, maybe few patients in some of these clinical trials were having GFR less than 15. Based on all of this data, they found that rivaroxaban 15 milligram or apixaban 2.5 twice daily in such patients were safe to be used. وافتكر ده ممكن يبقى الفيوتشر بتاع النواكس in such patients. وبرضه الفيوتشر طبعا احنا لغايه دلوقتي الميكانيكال هارت فالفز والمودريت سيفير مايترال ريزونانس ار كونترا انديكيشن للنواكس، بس ongoing trials may approve such drugs to be used in valvular atrial fibrillation.
Especially, I can add here, Dr. Nabil, this situation with severe renal disease and patient on dialysis, all anticoagulants are risky.
Yes.
Whether you give warfarin, whether you give NOAC, you are in a risky situation. Maybe one advantage of NOAC is that it is short acting, and if problem happen, you can by stopping the drug in few hours or half a day, you can eliminate its effect from the body, compared to warfarin, which you need 3 to 5 days.
Yes. That's a very important point, Dr. Ashraf. It's very important point that the half-life of the drug you are using, especially when patients develop bleeding, in NOACs, only 24 hours is enough, but in warfarin, you have to wait 3 to 5 days to get rid of the drug from the body of plasma level of the patients.
That's why the most important step to deal with any bleeding with NOAC is just wait and see till the bleeding stop by itself. Few hours.
Yes.
Sharif, any other questions?
هو على نفس البوينت اللي هو regarding the management of bleeding. If the patient happened انه حصل له bleeding while on anticoagulation, how to manage the bleeding.
Of course, as we just discussed with Professor Nabil, that the short half-life of NOAC is advantage in managing bleeding in such situations. Of course, if the bleeding is severe and not controlled by time, you may need the specific treatments. And we have some, in addition to blood transfusion, in addition to general support of the patients, we have some monoclonal antibody treatment for this type of bleeding. But I think the most important is, especially if the bleeding is moderate, not life-threatening, just by time it will, few hours it will stop in most cases, especially minor bleeding and mild to moderate bleeding.
أنا اتفضل دكتور نبيل.
دكتور اشرف، يعني you mean that ان الانتيدوتس اللي احنا عمالين نتكلم actually there is no antidote للوارفرين، برضه عشان الناس تبقى عارفه احنا عشان بيتكلموا على الانتيدوت we don't have an antidote to the warfarin. We treat bleeding due to warfarin in the usual way. ندي بلازما، ندي فيتامين كي، ندي الحاجات دي، ده ما there is no actually antidote to warfarin. انما we have now antidote اذا كان الدابيكاتران اللي هو الايزاريزوماب، وعندنا الانتيدوت للاكتيف فاكتور 10 انهبيتورز اللي هو الاندكسينات. والانتيدوتس دي ما بنستعملهمش غير في اللايف ثريتنينج بليدنج. حتى في الماينور بليدنج زي ما الدكتور اشرف قال انت ويت اند سي. وفي النون لايف ثريتنينج بليدنج، حتى نون لايف ثريتنينج ميجر بليدنج، بتبدا بتعالج السبب. لو عيان بيبتيك ألسر بتبدا تعالج البيبتيك ألسر. لو عيان بياخد كونكوميتنت دراجز، ممكن عيان بيكون بياخد نون ستيرويدال انتي انفلاماتوري، ممكن يكون عيان بياخد انتي بليتليت دراجز ان اديشن. لازم بتدور على الحاجات دي. وكمان حاجه مهمه جدا بيستعملوها في النون لايف ثريتنينج بليدنج ميجر بليدنج اللي هو بيسموه البروثرومبين كومبلكس كونسنتريت. ده من ضمن الحاجات المهمه جدا اللي بيستعملوها، مش بلازما، ما بيدوش بلازما ترانسفيوجن. الانتيدوت ده بيجي في اخر حاجه، وبيستعملوه في اللايف ثريتنينج بليدنج اللي هو الاندكسا ده. الاندكسا ده دلوقتي واخد FDA ابروفل. وعندنا الايداروسيزوماب للدابيكاتران انتيدوت برضو اخد FDA ابروفل. بس دول ريستريكتد فقط في حاجتين،
لايف ثريتنينج
لايف ثريتنينج ميجر بليدنج، او عيان محتاج ايرجنت سيرجري، يعني خلاص بياخد نواك ومحتاج ايرجنت سيرجري، ممكن ساعتها تديه الانتيدوت ده. يعني ده الكلام عليه.
تمام. I think we can conclude this.
هو في بس another question regarding the role of NOACs in patients with COVID-19.
Well, this is of course the questions of the day, because as you know, COVID-19 one of the important pathological mechanism of most of the complication happened with corona in critically ill patients, especially multi-organ failure, especially lung and pulmonary failure, is the thrombosis. And it is now a special category called COVID-associated coagulopathy. And that's why anticoagulation was an important part of the treatment of even moderate cases of corona or COVID-19. And there is now guidelines that any hospitalized patient with COVID-19 should be anticoagulated. We don't know the proper dose. Some recommend the usual prophylaxis, thromboembolism prophylaxis. Some recommend half therapeutic. Some recommend full therapeutic anticoagulation. And this may depend on the level of D-dimer and the level of fibrinogen. For example, if you have D-dimer above 1,000 or 1,500, your patient needs full anticoagulation, especially if the fibrinogen is normal or high. What anticoagulation? Well, heparin is the preferable, whether full dose, unfractionated, or low molecular weight heparin, especially in the first few days. However, because we wanted to decrease the contact between the nurse, the doctors, and the patients, we don't want to do frequent blood tests for PTT or for PT. Some advise NOAC from the start or after a few days of low molecular weight heparin, and even 1 or 2 months after discharge, especially for those moderate or critically ill patients who was having a high D-dimer test. Of course, our patient with AF or diabetes is a high-risk patient for COVID. He is taking NOAC, for example. We don't have any data about the prophylaxis role of NOAC in this patient if he developed COVID, but there is no problem in giving NOAC because, as I told you, even in COVID patients, we may need full anticoagulation.
ودكتور اشرف برضو كنت عايز اسال حاجه، يعني بمعنى لو البيشنت عنده اتريال فايبريليشن وماشي على نواك وجاله كوفيد محتاج هوسبيتال ادميشن، تو كونتينيو اون نواك ولا تو سويتش للو موليكولار ويت هيبرين في الحالات اللي زي دي يعني؟
Well, طبعا, of course, we have no data, but personally, I will continue NOAC.
Yes,
because
yes.
you know, this patient is critical patient. You don't want to try to adjust the dose and do some blood test, PTT or something. So keep him on NOAC and let us concentrate on the other part of the pathology and the therapy of COVID patient.
Amen.
Thank you, Professor Ashraf. Yes, and thank you, Professor Nabil. Yes, we can close. Yes, thank you so much for your elegant presentation.
It's very nice session, Dr. Nabil. I enjoyed being with you as usual.
Thank you, Dr. Ashraf.
Thank you, Byer, again, and thank you, ICOM, for their technical support. And see you in our future virtual CME activities.
Inshallah, بإذن الله. See you.
إن شاء الله. شكرا دكتور أشرف. شكرا دكتور نبيل. Thank you.
شكرا شكرا.
Thank you.